So we're here to talk about the erector mass, right? Now the erector mass, there's a lot of things that can really get between us as practitioners and understanding of what is or is not going on with the erector mass of the patient. Now when we look right here, we can palpate through broadly, right? Obviously for the effect of the video, I'm going to look at the camera more than I'm going to look at the patient. I'm going to kind of be splitting angles here. I can palpate broadly, right? I can compare side to side, right? I can compare side to side with two separate hands, okay? Contacting broadly, so the concept of get as much as you can touch. The rationale behind that is I want as much multi-point discrimination as possible for comparison, right? So if I do this, I can miss space. If I do this, I can miss, right? But if I do this, I can push in, get a broad idea of what's going on and narrow in as is necessary. So just on simple palpation, I can check through the erector mass in that way. I can try to push off, understanding that as the patient's seated, I would suspect that there's going to be a little bit more tone in the erector mass in order to do the job, which is keep the patient upright. Now, as far as assessing motion characteristics of the erector mass, globally or broadly, I can very simply have the patient move. Now, the challenge here is that there's going to be a lot of co-contractors. There's going to be a lot of noise in the signal, if you will. So we're going to have the patient bend to the right. Okay. Now, as he goes there, we can see the general motion of the vertebral column, and this looks like reasonable motion. We can pause him, so like pressing pause on YouTube, and scan, and that's essentially our motion test. So when we pause the patient, we get the patient to move, and we pause them, and then we check. That is a motion test. They've just stopped. They've created motion and stopped. And we'll have them go the other way. Okay. Now, in a comparative sense, right, we'll have them come back just for the comparison because I didn't see it appropriately. That works quite well. And we have them come this way. That doesn't work as well, right? So using my eyes, not necessarily my palpatory sense, there's a fair amount of tension right in here. This area doesn't want to let go. It will shorten quite well. He'll bend to the right quite well. He won't bend as well as left. Not poorly, but not as well. And there's a visual signal that I get here of tension. Now, if he comes back up, we'll just briefly discuss what the problem here is. We've got the internal external obliques working, we've got the latissimus dorsi working, we've got multiple other muscles working, so we can infer that what we have here is a shortened right erector mass compared to the left. So the right will shorten, will not lengthen. The left will move relatively freely, but because the right side won't do its job, we have a problem. But can I truly differentiate that from the obliques or the lat, or if we want to make an assumption or we want to really kind of push out beyond the boundaries of what's understood, we can say maybe the trapezius, although the lower fibers of the trapezius are not particularly thick, even in well-developed people, unless they're very, very large bodybuilders. Now, we know that we have a motion bias to the right in the coronal plane. We don't necessarily know much else. We haven't ruled anything out. So what we're going to have you do is we're going to have you lay with this side up. So now one of the things that we run into here is that we can assess the erector mass and lateral on one side, so we don't get very good comparison, right? What we get is kind of unilateral information. Now, to assess with multi-point discrimination, you'll often see me do something like this. So I get a bar, I get a lot of information, and I can peel the erector mass away and just try. So I can identify the SPs, move up or lateral to the SPs, and push through the erector mass. So I can see what it's like in a position where there's less tension on it. What you will often see, now the reason that I'm doing this from behind is because I can see it, so I won't get tricked. Now what you'll often see is practitioners go to the other side of the patient and you'll see them reach, okay? Now, as far as patient positioning is concerned, I'm not necessarily being overly picky right now. I just want you to see this. They will reach, right? And they'll pull up. Now, while that is perfectly valid, we're cutting one of the senses off, and also as you can see the patient rock a little bit. Now, if I want to be as accurate as possible, I have to stop the patient from moving, because I'll get the inference of extra motion in the erector mass where none is happening because I'm rocking the patient. So a way to deal with that is to drape the forearms across the flank of the patient, the mid-axillary line, however you want to term it, and wrap, right? And I wouldn't suggest you do it one at a time, one hand at a time. Make a bar again, right? So now you can pull on the erector mass. So as far as a palpatory sense, this is a more accurate palpatory sense because I'm not getting auxiliary motion of the patient. And I'm getting a good amount of muscle at the same time. Okay? Now regardless of findings, what I'm trying to suggest is how to do this more appropriately, because this becomes a problem, and you'll see practitioners rolling through in this fashion. Now while they may get accurate information, it's just less likely, because again, auxiliary motion of the patient. Okay? And what I would suggest in most cases, if you're trying to check the actual erector mass, is to do short lever motion testing of the muscle, because if you push into a muscle or soft tissue, it should deform evenly under your hand. That is a motion test. We're actually going to have you laying on your stomach for a moment. So as a comparative, right, so we found that the patient preferred to side bend to the right globally, motion to the right in the coronal plane. Now I'm checking the left side because I'm across table, so if I push in here, I just won't get as much information. The preference is to take the erector mass and push it away from attachments to see if it will yield. Now what you'll see is a lot of people pushing like this, and you'll see my hand slide. Now to get the erector mass and to have some understanding of what it's doing, the heel of the hand should contact the spinous processes, move slightly lateral towards the laminar groove to the best of your capacity, and you push away. Now what the expectation is, so as I'm pushing, I'm again broad contact, not taking large jumps so that I don't miss information. The expectation, generally speaking, is because the right side prefers to shorten and not lengthen, the left side should actually feel like it's somewhat higher tone, right? And what we can really do, regardless of which side we're more concerned with, is we can compare one area to the other. The erector mass in the lumbar column should feel a little bit softer overall in most cases because there's no ribs there. Because of the ribs in the relation to the muscles, right, we expect a little bit more tension in the mid-thoracic region in here. Then we get up into the scapular tissues or the medial scapular tissues, which should also obscure this. So again, that broad contact, pushing away, that is moving the patient's shirt and some of their skin, obviously some of their muscles as well, but it's not as useful as we want. So I can short lever motion test away from attachment sites, the erector mass, and then I can come around to the other side. Now again, my expectation is generally that this side should be softer than this side. So I would come around, and again, short lever motion test. And so far, this side feels, in a comparative sense, softer than the other side. So that shortened muscle, that muscle that prefers to be shortened, will often come back in a palpatory sense, right? So a visual sense, I can see it moving, and I can see that I'm not moving beyond what I'm trying to move. Using the concepts of multisensory integration, this feels more flaccid, right? So I can treat that. Because this is the shortened side, this is the side that actually needs the attention. While this may be harder, this side needs to be willing to lengthen, so I can go about lengthening just with a simple push-off, right? Myofascial release, holding, waiting, whether that's a neurological phenomena or otherwise. What I can do, what I've noticed through clinical practice, is that I can hold that, and as I hold it, we can get change. The other challenge that we have, so just to compare and contrast this as far as visual information, so in lateral we can really work well on one side. We see better when we're behind the patient. We can control the patient's motion from the front, essentially by draping over and stabilizing the torso. We can see both sides in prone, work freely on both sides in prone, short lever motion testing if we have you on your back. We can attempt to test the erector mass here, essentially by having a hand or multiple hands underneath the patient and creating a pull. Now the problem that we have is that we're working in the dark. We can't see. Our capacity to compare is minimized because we have to go up the entire column, side to side, get the arms out of the way, and then go to the other side. We're working blind. So here's the benefit of putting the patient in prone. We can work on both sides, essentially one right after the other, without moving the patient much. You can see everything, and you can access it all. So that's the fourth concept in patient positioning. The anatomy should be exposed, free to move in the plane required, and preferably visible. Now in lateral, we've got pretty much all of that as well, but we can only effectively work on one side.